diseases, of non-communicable diseases. So we know we are in low and middle income countries, so probably we are dealing a lot with infectious diseases. However, we need to know that the leading causes of death are actually cardiovascular diseases. Now, HIV for a long time has been in the top 10 list, but as you can see, it's moved down, I think, to number 19 or so, according to this WHO global estimates up to 2020. And as you can see, diabetes is up to 9. So that means we need to take NCDs seriously. So cardiovascular disease remains the #1 cause of death globally. It contributes to about 1/3 of the deaths. And even though, as I've emphasized, we concentrate more on infectious diseases, more than 3/4 of deaths from cardiovascular disease actually occur in low and middle income countries. And for those of us who have been in clinical areas, who have taken care of adults, for example, we know that most of the patients that we lose are those with cardiovascular diseases. So in the US, they have done a lot to reduce the incidence of deaths from cardiovascular diseases from about what they were in the 1960s by 1/3 due to some of the interventions that they have put in place. Despite this, they have also noticed a stagnation for those aged about 55 years, especially women, and it's thought that some of the events around the pregnancy may actually contribute to this stagnation. In low and middle income countries, as usual, we have limited data. So what are these adverse outcomes of pregnancy that have been associated with cardiovascular disease risk? So not all pregnancies are associated with cardiovascular disease risk. There are some pregnancies with some complications, which we call adverse pregnancy outcomes, which have been shown consistently to be associated with cardiovascular disease risk. So some of these include hypertensive disorders in pregnancy of new onset, like preeclampsia and gestational hypertension, gestational diabetes that is occurring for the first time in pregnancy, preterm delivery, growth restriction, low birth weight, or infants who are small for gestational age. Even large birth weight has been associated with increased risk as well, and placental abruption. Because of this recognition of adverse pregnancy outcomes and increased risk of cardiovascular disease, the American Heart Association and the NIH, National Institutes of Health, have included adverse pregnancy outcomes for the first time in their annual data on heart disease and stroke statistics. So they are taking it seriously. And what does this mean? That if you're working in the obstetric field, you need to know that your patients are at risk of future cardiovascular disease, and therefore you need to counsel them appropriately and take good care of them beyond the preparatory period. Now, if you're working in medicine, for example, or primary care, then you need to ensure that among the risk factors that you get for your patients, look for adverse pregnancy outcomes when you're looking at their risk of future cardiovascular disease. So it's very, very important. Just a bit more evidence to support this. So there are several studies that have been done, especially in high income settings, that have shown, confirmed some of these findings. So the strength of evidence is considered at A in this review that was done by Nishal Parikh. If there are multiple consistent cohort studies or meta-analysis of such studies. However, if there are fewer available studies or inconsistencies in the evidence, then that evidence was categorized as B. So as you can see, majority of the evidence that we have is category A, showing that some of these adverse pregnancy outcomes like hypertension, gestational diabetes, preterm birth, small or large for gestational age, abruption placenta, miscarriages or stillbirths are associated with cardiovascular disease risk. Now, how common are these conditions in our globally and in our setup? So about 20%, according to the global estimates, 20% of pregnancies are complicated with these adverse pregnancy outcomes. This number may be higher. For example, if we don't screen for gestational diabetes in our setup, our prevalence may be about 2 to 3%. But if we screen, we find the prevalence going as high as 14 or even 24%, depending on the setup. So that means that the prevalence of these adverse pregnancy outcomes may be higher, especially in our setup. But globally, it's estimated at about 20%, okay? So 2 or 3 out of 10 patients that will be taken care of may have adverse pregnancy outcome and therefore may be at risk of future cardiovascular disease. Now, for a long time, we have been looking at the risk of cardiovascular disease when we follow these women for a longer period of time, let's say, for example, 10 years. So some of the initial studies were studies that were done in large populations over a long period of time, especially in the Scandinavian countries, looking at women probably in their 60s or in their 50s and trying to look back and see whether they had some of these adverse pregnancy outcomes and looking at the outcomes that they have, for example, hypertension, cardiovascular disease, stroke, and the rest. However, studies also show that actually below 10 years, you can identify some of these cardiovascular disease outcomes. For example, hypertension is higher 3 times, and cardiovascular disease in general higher 2 times, even within less than 10 years. When you look at patients who had hypertensive disorders in pregnancy versus those who are normotensive, okay? And the risk increases as the duration of follow-up also increases. Now, this is additional evidence to show that having hypertensive disorders in first pregnancy increases one's risk of future cardiovascular disease. What this forest plot shows you that if there is no risk that is at a level of 1, okay, if you're at a level of 1, then everything else will be crossing that line, and maybe if it is reduced towards the left. But as you can see, there's increased risk because everything is on the right side and doesn't include that null or level at which the risk could basically be the same. So basically what this tells us is having hypertensive disorders in first pregnancy is associated with increased risk of cardiovascular disease, coronary heart disease, stroke, okay? And even if they just have history of gestational hypertension alone, again, that is associated with increased risk. What if they have more than 1 pregnancy with hypertensive disorders in pregnancy? The risk is even higher for some of these adverse cardiovascular disease outcomes, okay? Now, what if they have like hypertensive disorders in pregnancy, they end up with a preterm delivery and a small for gestational age? Then this even multiplies the risk to a higher level. So there's a multiplicative effect if they have not 1, but more than 1 of these adverse pregnancy outcomes. So in as much as we are interested in the immediate maternal and neonatal outcome, we need to be really, really concerned about their future cardiovascular disease risk. So then the next question we need to ask is why? Why is that a previous history of these adverse pregnancy outcomes, and specifically preeclampsia and gestational hypertension, associated with future cardiovascular disease risk? Now, it is thought that there could be shared risks, okay, for these conditions, that is hypertensive disorders in pregnancy and cardiovascular disease, or it could be pregnancy mediated, okay? So the first theory of shared risk says that there may be some underlying shared modifiable pre-pregnancy risk factors that puts these women at risk of developing preeclampsia and gestational hypertension. Then later, this now manifests as cardiovascular disease. So pregnancy acts as a test to test and show us who is at risk of developing this pregnancy, adverse pregnancy outcomes, and therefore cardiovascular disease. And some of the underlying etiologies include increased insulin resistance that we see, especially in those patients with gestational diabetes, endothelial dysfunction that we know is common in patients with hypertensive disorders in pregnancy, especially preeclampsia and gestational hypertension, overwhelming systemic inflammatory response, again, due to the similar underlying pathology and susceptibility genes, because we know that some of these conditions also run in families. Then the other theory is that pregnancy itself accelerates the atherosclerosis and myocardial changes, which later now become sort of permanent. So pregnancy and preeclampsia associated with changes in the lipid profile, excessive inflammation, angiogenic imbalances, metabolic and vascular maladaptation that persist now beyond the pregnancy period. So now that, at least from the evidence that we have, we know that there's increased cardiovascular disease risk. So what do we do? Okay, so far in our setup, we are not doing much, but task forces from the NIH and even the National Institute of Health and other cardiovascular disease, American Heart Association, and other people interested in cardiovascular disease have tried to address this topic. So how do we reduce cardiovascular risk after adverse pregnancy outcomes or hypertensive disorders in pregnancy? So the questions they have been battling with is, do we target women at highest risk? For example, those who had severe forms of the disease? Do we use clinical pregnancy outcomes to determine those who are at risk and follow them closely? Do we offer them targeted screening? And even if we offer them targeted screening, what kind of screening do we need to offer them? What kind of interventions do we offer them? Because it's not enough just to offer them screening. What kind of interventions do you offer them? How do you follow them up? Okay, what are the best screening tools? Are they biochemical markers? Are they clinical markers? Are they inflammatory markers? Or are they imaging modalities? So those are some of the questions that people have been grappling with, even in the high income countries. So the American Heart Association decided to recommend, as last year, some form of follow-up for these particular patients to detect and prevent cardiovascular disease after hypertensive disorders in pregnancy. So they said at 6 weeks, we need to follow them up. In addition to routine checkup, obstetric or neonatal checkup, we need to evaluate their cardiovascular risk factors. So you check their blood pressure, you check their BMI, okay, and talk to them about lifestyle changes. So you need to talk to them about weight reduction, diet, exercise, and other things that can lower their risk of developing cardiovascular disease. Now, that can be done by the obstetrician or a primary care provider. They also recommended that you can continue with the same 8 to 12 weeks. Again, follow them up, as you can see, emphasizing blood pressure, BMI, for example, and lifestyle modification. You can continue with the same at 6 months, okay, as you follow them up. And most of our patients in obstetrics will see us at 6 months before we transition them over to their primary care provider if they have a different one. And then at 12 months, you do the same. And after that, see them annually, okay? So this is care that can be provided by the obstetrician or can also be provided by the primary care provider or physician, or they can work together to manage the patient appropriately. So such patients are not recommended just to be told to go to the clinic, offer them family planning, and that's the end. You need to offer them more than that. Now, I'm comparing this with the NICE guidelines from the UK. Again, very non-specific, but suggesting similar things. So 6 to 8 weeks after delivery, you assess their risk. Hypertension, obesity, smoking, and dyslipidemia should be addressed. Discuss future cardiovascular disease risk. Encourage healthy lifestyle, including diet, and consider starting therapy in women that you have scored and found at the risk of 5 to 7.5%. Okay, so for them, they are even recommending initiation of treatment earlier. And then after that, you follow them annually or every 5 years. Again, very non-specific, starting 6 to 12 months after delivery. Again, assessing risk, encouraging healthy lifestyle. And then at 50 years of age, do cardiovascular risk assessment and manage appropriately. Okay, now what these two kinds of recommendations do not consider is that some of these patients would be having their first pregnancy, and therefore, if you transition them to the primary care provider, who is a physician or a family practice or a clinical officer in our setting, then you have transitioned them back to the obstetrician. So somewhere along this pathway, the obstetrician would still need to take care of them, or the midwife or whoever is taking care of these patients. So then, having looked at what they assess, and that includes hypertension and obesity, we thought amongst our population, what are some of the things that we can measure that can help us to identify the cardiovascular disease risk, so that we do not just talk to them about maintain your blood, maintain your blood pressure, keep them low, diet. There must be some tools that you can measure that can help you determine their risk. So that's why we looked at metabolic syndrome and its risk of cardiovascular disease. So from literature, consistently, we find that those with metabolic syndrome, which is a cluster of 5 characteristics: high triglycerides, low cholesterol, HDL cholesterol, abdominal obesity, hyperglycemia, and hypertension, are at increased risk of cardiovascular disease, which is estimated at 2-fold or even higher. And the spectrum of cardiovascular disease that you can get when you have metabolic syndrome include ischemic heart disease, or overall cardiovascular disease mortality, all-cause mortality, or even type 2 diabetes mellitus. The burden of metabolic syndrome, as you can guess, is increasing globally, including in our setting. So when the first estimated, it was about 5%, but now it's going up to 40%, and it's increasing. A study done by Kaduka in 2012 from Cambridge estimated this to be about 35% in our population, and women had higher metabolic syndrome compared to men at about 40 to 29%. In Ghana, the estimate is about 36%. Again, women higher than men. And in Ghana, it was significantly higher, okay? In the US, again, the numbers have been increasing as far as metabolic syndrome is concerned. So it's something that we are consistently living with. Now, for a long time, it has been difficult to agree on how to measure metabolic syndrome. So different bodies had different diagnostic criteria. For example, the NCEPT NIH had an absolute criteria and additional criteria of any 3, okay? And some of these criteria required intensive laboratory testing. WHO also had their criteria. American Heart Association also had their criteria. So everybody sat down and they got into a consensus in 2009 and said that let's look at things that can be easily measured, okay? Because things like insulin resistance may not be easily measured in all settings. And therefore they decided that a presence of any 3 of these 5 would be diagnostic. So any 3 of waist circumference, which is our abdominal obesity, high triglycerides, low levels of HDL cholesterol, blood pressure 130/85 or higher, or a fasting plasma glucose of 100 or higher would be diagnostic of metabolic syndrome. So that's the criteria that consistently is being used and the one that we've used in our studies. So out of interest, we decided to look at the risk of metabolic syndrome after hypertensive disorders in pregnancy. By the time we were designing this study, there were no studies actually on this topic in our setting. But overall, we found that there was higher risk of metabolic syndrome after hypertensive disorders in pregnancy, which was 2 times or higher. But these studies were in heterogeneous populations, predominantly in high-income settings, and as mentioned, very few studies in Kenya or sub-Saharan Africa. Since our publication, at least we have had 3 studies done in sub-Saharan Africa. So in our study that we did locally, we were looking at the risk of developing metabolic syndrome after hypertensive disorders in pregnancy, and we had 3 specific aims. The first aim was to determine the prevalence of metabolic syndrome, comparing women with versus those without hypertensive disorders in pregnancy and or gestational diabetes at different time points, that is 6 months, 1 year, 2 years, and 3 years after delivery. The idea was to see whether these patients are more likely to develop metabolic syndrome early in the postpartum period or later in the postpartum period. And then the second objective, to determine some of the correlates, sociodemographic and clinical, of women who have metabolic syndrome compared to those who do not have metabolic syndrome, again at the same time point. So in this particular aim, we are saying, let's look at those who have metabolic syndrome, because pregnancy itself may put you at risk of developing metabolic syndrome even without having other risk factors, and then look back and compare whether hypertension is a risk factor for metabolic syndrome and whether there are other correlates of metabolic syndrome as well. And then lastly, as we were talking about the underlying etiology or pathogenesis, which is increased inflammation and insulin resistance, we wanted to look at the inflammatory markers, specifically high sensitivity C-reactive protein between women who had versus those who did not have metabolic syndrome at the different time points, and also stratify that by presence of hypertensive disorders in pregnancy. So we designed a prospective cohort study in which we recruited women and followed them up. Our population were women who were followed at the different time points. Exposure was having hypertensive disorders in pregnancy and or gestational diabetes. And the non-exposed group had normal blood pressures during pregnancy and the postpartum period. Our outcome was metabolic syndrome, and the study duration was 3 years, beginning in 2016. So our inclusion criteria were for those who are aged 28 years and higher. And these have been asked before to explain why. The idea was the younger patients, we thought that the younger patients may actually desire pregnancy sooner compared to those who are slightly older, not old, but slightly older than those. And that's why we had a cutoff of 28 years. They had to be HIV negative because HIV and its treatment has been associated with a slight increase in risk of metabolic syndrome. They had to be not planning to be pregnant for 3 years. And that's why, again, we went for 28 years rather than younger. They had to be residents of Nairobi or suburbs and within 50 kilometers from Kenyatta for ease of follow-up. Then in our exclusion, we excluded anyone who was at risk of metabolic syndrome if they had hypertension, diabetes, cancer, renal, hepatic, or biliary disease, or if they're using medications which were suggestive of them having had one or more components of metabolic syndrome. Patients who are unstable were not able to give consent, and those who are not willing to be followed up for the duration of time of 3 years. So what we did is we screened these women at discharge. So when they were ready for discharge, we screened them and checked their eligibility and determined their exposure from the medical records, what the doctors wrote in the file and the nurses, and then also asked them to confirm whether they had hypertension before pregnancy or during the first 20 weeks of pregnancy so that we could exclude them. Then we enrolled them within 12 weeks postpartum at the study clinic. And the 12 weeks was chosen because we wanted only those who were committed to the study who were able to come back for follow-up within those 12 weeks to be followed up because we didn't want high loss to follow up. Then we conducted interviews and physical examinations when they came in, specifically checking their blood pressures and checking their weight and height and abdominal circumference. Then we followed them up at 6 to 36 months postpartum, again conducting interviews, physical examination, and drawing bloods for lipid profile, inflammatory markers as well to be able to help us make a diagnosis of metabolic syndrome. So what are the results of our study? For this first specific aim, which was to determine the prevalence of metabolic syndrome in women with versus those without hypertensive disorders in pregnancy at 6 months post-delivery. So we have data from 12, 24, and 36 months, but we'll just present the data at 6 months postpartum. So we screened about 266 women. Several were ineligible, either because they withdrew before enrollment, relocated, or were not traceable. So we ended up enrolling 213 for this analysis. 70 were exposed, and twice that number were unexposed. And 63 had completed 6-month follow-up by the time we were conducting the analysis, compared to 131 for those who were exposed versus unexposed, respectively. When we compared their baseline characteristics, they were essentially similar for a majority of the variables. For example, the age was the same, around 33 years. Most were married, had secondary or higher education, employed, had used some hormonal contraception before pregnancy. And however, they had higher parity if they were hypertensive, again, probably because they had had some bad outcomes before and were desiring another pregnancy sooner. And the gestational age at delivery, as you can see, was lower in those who are hypertensive compared to those who are normotensive. Again, because if they develop high blood pressures, we tend to deliver them at an earlier gestational age. So those were the main differences on that slide. In the next slide, we looked at other baseline characteristics when we enrolled them, and I'll just concentrate on those who are significantly different. So the birth weights were lower in those who are hypertensive. And again, this is understandable because of the lower gestational age and the effect of hypertensive disorders in pregnancy or on birth weight. We had more stillbirths or neonatal deaths. Actually, close to 30% of these women either had a stillbirth or a neonatal death compared to 6%. The neonatal deaths or stillbirths are higher because we are a referral institution, but significantly higher among the exposed group. Exclusive breastfeeding was higher, probably because these infants were being monitored closely, and therefore the mothers were encouraged to continue exclusive breastfeeding. The rest were expected. Systolic blood pressure was expected to be higher. The diastolic blood pressure again was expected to be higher, and the body mass index again was expected to be higher in the hypertensive group. So when we looked at the risk of metabolic syndrome, we found that it was 3 times greater, a prevalence of 35% versus about 12%, okay? So that was 3 times greater risk of metabolic syndrome at 6 months postpartum, comparing those who are hypertensive versus those who are normotensive, okay? In adjusted, relative risk was 3.05, and again, this was statistically significant with a relatively narrow confidence interval. So demonstrating our hypothesis, confirming our hypothesis that hypertensive disorders in pregnancy is associated with increased risk of metabolic syndrome as early as 6 months postpartum. Now we went further to look at the components of metabolic syndrome and see which ones were actually associated with hypertensive disorders in pregnancy. So overall, we said 3 or more components. So we've estimated the risk at about 35 versus 12%. Blood pressure was elevated in the hypertensive group. Triglycerides, again, was elevated in the hypertensive group, and fasting plasma glucose was also elevated in the hypertensive groups with p-values less than 0.05 in all those. The cholesterol and the waist circumference was not statistically significantly different between the 2 groups. So we adjusted to see whether if we adjusted for some of the confounders, this association would disappear. And as you can see, when we adjusted for age, education, BMI, marital status, employment status, use of hormonal contraception, and breastfeeding, the association remained statistically significant for all the markers. So metabolic syndrome, BP, triglycerides, fasting plasma glucose. So what are the conclusions from this first specific aim? That we have a high risk of metabolic syndrome following hypertensive disorders in pregnancy in this setting. Is actually comparable or higher than what has been reported in other settings. And the main components that were elevated were triglycerides, blood pressure, and fasting plasma glucose. So for those who want to read more about this study, you can check in Pregnancy Hypertension, where it was published, and also it's been included in one of the systematic reviews by the British Journal of Obstetrics and Gynecology. So additional findings that I'm not able to present here because of time can be read from that paper. In our second specific aim or objective, we wanted to determine the sociodemographic and clinical correlates of women who had metabolic syndrome compared to those who did not have metabolic syndrome at 6 months after delivery. So when we looked at the risk factors that we had determined a priori, we found that age was not associated with increased risk. Hypertensive disorders in pregnancy, however, was associated with a 4-fold increase in odds. Secondary education or higher was protective, reduced odds. And then body mass index was associated with increased risk. The others were not associated with increased risk or odds of developing metabolic syndrome. So mainly hypertension, as we had hypothesized, secondary education, and a BMI of more than 30 kilograms per meter squared. So again, this was evident in either the crude analysis or adjusted analysis as well. So again, from this second objective, the conclusions were correlates of metabolic syndrome postpartum at 6 months were hypertensive disorders in pregnancy and a higher BMI or obesity and below secondary level of education. So that means if you want to address this going forward, we must address these main correlates. Our last specific objective or aim was to compare the levels of inflammatory markers, specifically high sensitivity CRP, between women with and those without metabolic syndrome at 6 months post-delivery. So again, just to review why we were thinking that this was an important thing to evaluate. So CRP, as we know, is a marker of inflammation. and an independent predictor of cardiovascular disease. Now, the studies have been done by several people, including Radka, who has done a lot of work on CRP, and have found that the effect size for cardiovascular disease, looking at CRP, is similar to that what you could get from total and HDL cholesterol and elevated blood pressure. So it's something that we need to consider seriously. So the theory behind this is that if you have inflammatory risk factors like obesity, dyslipidemia, insulin resistance, or hypoxia, then this leads to production of pro-IL-1 beta, which is converted to active IL-1 beta. And IL-1 beta is converted to IL-6, interleukin 6, and then this is now converted to CRP. And then therefore CRP will be a marker of this inflammatory process. Now, we need to make a distinction between the standard CRP, which we sometimes do for other indications, versus the high sensitivity CRP. So high sensitivity CRP is specific to cardiovascular disease risk. So we don't use the standard CRP. So some of the reasons given for this are that the standard CRP is reliable above 10, while the high sensitivity CRP is reliable below 10. So even when you are doing your analysis, if you see values above 10 for high sensitivity CRP, we tend to evaluate them as if there was an acute inflammatory process going on rather than a chronic inflammatory process going on, okay? And when you look at high sensitivity CRP, when you now subdivide it into different categories, levels less than 1 have been associated with lower relative cardiovascular disease risk. 1 to 3 is average relative cardiovascular disease risk, and then more than 3 is high relative cardiovascular disease risk. So when you want to look at the risk of your patients, if you're using HSCRP, then you need to consider levels above 1 and more specifically levels above 3 to estimate the relative risk of cardiovascular disease for your particular patient. So what were the results of this specific objective? So we found that if we looked at women who had postpartum metabolic syndrome versus those who did not have, then the high sensitivity CRP was higher, about 4.7 versus 2.1 in those who did not have metabolic syndrome. So again, confirming to us that there's underlying chronic inflammatory process in those patients with metabolic syndrome in the postpartum period. When we subdivided this into those women who had hypertensive disorders, but those who are normotensive, again, we found a difference between those who had metabolic and those who did not have metabolic syndrome. The risk, the level was about 4.4, the median was about 4.4 versus 1.7, okay? And that was statistically significant for hypertension. For those who are normotensive, the levels were higher, again, about 4.1 versus 2.2, but that was not statistically significantly different. In terms of numbers, again, we found that high sensitivity CRP levels were higher in patients who had metabolic syndrome. So relative risk of 1.7, adjusted 1.4, and it was statistically significant. But when you subdivided them into the hypertensive group versus normotensive group, then it only remained significant in the hypertensive group, even after adjusting for age and body mass index. Again, confirming that metabolic syndrome is associated with increased inflammation, and especially among those who had hypertensive disorders in pregnancy. Again, confirming the hypothesis that we have. So in conclusion, CRP, high sensitivity CRP was significantly high among women who had versus those who did not have metabolic syndrome, and the risk was significantly higher among women with hypertensive disorders in pregnancy. However, the risk was lower, but not statistically significant among those who are normotensive. Again, this work was also published in Gynecology and Obstetrics. For those who want to read more about the methodology and additional findings, you can read that paper, which was published same time last year in that journal. So back to our slide, what do we do next? So we've shown in our study setting that we have increased risk of metabolic syndrome, which is a marker of future cardiovascular disease. We also know that we have increased risk of inflammation, okay, which is also a risk of cardiovascular disease. So again, the questions remain. Do we target women at highest risk? Do we use clinical pregnancy outcomes, targeted screening? What are the best interventions? What are the kind of follow-ups that we need? What are the best screening tools? Biochemical, clinical, inflammatory imaging, we've at least raised some issues about clinical, from metabolic syndrome, biochemical markers as well, inflammatory markers as well. What about imaging? So that was our next question. Can imaging help us identify women who are at risk of developing cardiovascular disease after hypertensive disorders in pregnancy? So again, we did a bit of literature review, and we found out that the angiogenic imbalance in preeclampsia or hypertensive disorders in pregnancy seems to resolve after pregnancy. Yet some of the cardiac changes that have been associated with preeclampsia persist for at least a year in some studies. Now we are saying, how do we identify these changes? We thought that advanced imaging may describe some current and long-term cardiac dysfunction after hypertensive disorders in pregnancy. So using your standard imaging, using your standard echo, you may not be able to pick some of this cardiac dysfunction, but maybe using some advanced imaging, we may be able to pick some of this cardiac dysfunction and use them to monitor patients, use them probably to triage our patients and take good care of them. So one of these advanced imaging modalities is called Speckle tracking echocardiography. So it's an echo technique that analyzes the degree of myocardial deformation, also called the strain, throughout the cardiac cycle. And this creates speckles by the regular reflection of the ultrasound that can be tracked throughout the cardiac cycle. And speckle tracking is an automated measurement of the distance between speckles in a specific ventricular segment or region of interest. So speckle automatically will be able to be tracked and be able to measure and tell you the degree of strain that the myocardium is undergoing. So the advantages of the speckle tracking echocardiography is that allows measurement of longitudinal, radial, and circumferential strains of the myocardium. And these measurements can be used to prognosticate changes in the left ventricular function. And the speckle tracking echocardiography characterizes very subtle changes in myocardial contraction and relaxation before one sees the gross changes that are associated with volumetric indices such as ejection fraction. So some patients may have a normal ejection fraction, yet they already have pre-existing cardiac dysfunction. And those are the patients that you really, really want to pick using speckle tracking echocardiography. So speckle tracking echocardiography may be a sensitive tool for risk stratification, as I mentioned earlier. So you can try and identify those who are at the highest risk of developing cardiovascular disease or at some adverse outcome related to any form of treatment. It can also be used to monitor response to disease progression. And this is used a lot in cancer patients in some settings, especially where we did our training for this. It's done before every cycle of chemotherapy to try and see whether the patients are stable enough to continue with their next cycle of chemotherapy. It can also be used to monitor response to interventions. So if you offer any treatment to your patient, you can be able to monitor using speckle tracking echocardiography if their cardiac dysfunction is improving or not. So we decided to use our study population and recruit a new group of women to try and evaluate the role of speckle tracking echocardiography in assessing cardiac dysfunction in our setting. So among women who had and those who did not have recent hypertensive disorders in pregnancy, who are within 6 weeks and are 2 to 3 years postpartum, we sought to compare the prevalence of subclinical cardiac dysfunction by measuring the myocardial strain using speckle tracking echocardiography, and also to ascertain the association between the subclinical cardiac dysfunction and serum levels of inflammatory markers like IL-1, 8, high sensitivity CRP, and tumor necrosis factor alpha. So what we did is we relied on our ongoing cohort that we have been following and also recruited a new cohort to evaluate those who are within 6 weeks postpartum. So it's basically a cross-sectional study on 2 separate but closely linked populations, a newly recruited group of women with and without hypertensive disorders pregnancy, and then an ongoing cohort of women that we are following up who are at 2 to 3 years upon recruitment. So again, very similar population, so and eligibility criteria. However, because we are not expecting to follow up for long, those who are newly recruited, we lowered their age to 18 years rather than 28 years. The rest were essentially similar. And then for those who are 2 to 3 years, we evaluated their lipid markers, lipid profile, fasting plasma glucose, and other biomarkers of inflammation as well. And they did Speckle tracking echocardiography in all of them. So transthoracic echo was done by a trained sonographer blinded to participant diagnosis. So we took a sonographer to the US for training. He spent, I think Joseph spent about a month training there because we didn't have Speckle tracking echocardiography within Kenyatta National Hospital that particular time. So we had to buy the machine and also take our sonographer out for training so that at least he could be able to come back and be able to conduct the studies in this setting and have a quality check by our colleagues from the University of Washington in the United States. So we acquired the images and stored them to allow for retrieval and detailed analysis by Joseph and our sonographer and our team from the University of Washington. And then we collected a lot of data, including left atrial size, volume, and function, systolic and diastolic function, left ventricular strain, valvular function, global longitudinal strain, and rates using the STE software. So we had a lot of information which we can later analyze to assess differences between the two groups, but we will just present some preliminary data that we have. So far, we screened about 205 women in the postpartum period, enrolled about 154 of them who are eligible and were able to give informed consent, half in the hypertensive group and half in the normotensive group. The baseline characteristics were essentially similar for most of them. However, some of the findings that we had before in our cohort that we had presented earlier were more or less similar, like the lower gestational age for those who are hypertensive, for example, okay, and the maternal weight and the parity. The other findings which were also similar and also important to note was that by the time the patients were being recruited, the baby was either live with the mother or nursery in about 72% for those who are hypertensive versus normotensive, which was 97%. So, and baby being alive in nursery was about 27% for the hypertensive versus normotensive, which is 4%. So it just tells us how many babies we are actually losing because of hypertensive disorders in pregnancy. And that means we really need to improve on our care to ensure that we don't lose these babies either in utero or immediately after delivery in the neonatal period. The birth weights as expected were lower in the hypertensive group, and the high blood pressures were more common in the hypertensive group as well. So these were things that we actually expected. When we looked at the measures of cardiac dysfunction, when we used our global longitudinal strain and using a cutoff of -18 for the strain, there was actually no difference between the two groups, okay? When we changed it to a lower level of -20, again, there was no difference between the two groups. As you can see, the proportion which was having this measure of cardiac dysfunction was slightly higher in the hypertensive group, but essentially they were similar between the two groups. We don't know what will happen once we recruited everybody, but the trend we are seeing is that there's a bit of similarity. It may be because of the physiological changes in pregnancy, for instance, that may also contribute to some of the changes in the GLS. We don't know. What we found to be significantly different is the left ventricular mass, which is a measure of left ventricular hypertrophy, okay, which was elevated in both groups, but was higher in the hypertensive group. So this is something that we need to watch going forward. When we looked at the women 2 to 3 years postpartum, we found now that the GLS, the global longitudinal strain, the abnormalities were higher in the hypertensive compared to the normotensive group. The numbers are again small, okay, but there's at least a trend towards statistical significance. So for the level of -18 or -20, we showed some difference. And again, we showed a persistence of difference in the left ventricular mass. These are preliminary results. Once we have the final numbers, we may be able to make more inferences. But this is what we are seeing as at the moment. And we are almost done with our recruitment. So this may not change very much, but this is what we are seeing. So in conclusion and in summary, adverse pregnancy outcomes, including hypertensive disorders in pregnancy, as we can see from the evidence that we have shared, are associated with increased risk of cardiovascular disease, which is the #1 cause of death globally. So my hope is that at the end of this discussion, we can remember that hypertensive disorders in pregnancy has an effect on our women beyond the puerperium, beyond the 6 to 12 weeks puerperium. So we need to really think beyond puerperium when we are taking care of these patients, okay? And whether it's the first pregnancy or the subsequent pregnancy, the risk is there. So once they have that risk, please ensure that you address their cardiovascular disease risk going forward, okay? In our study, we found that hypertensive disorders in pregnancy is associated with a 3-fold higher risk of postpartum metabolic syndrome as early as 6 months in the postpartum period. So we are still waiting to complete analysis of our data at 12, 24, and 36 months, but as early as 6 months postpartum, we have increased risk of postpartum metabolic syndrome, okay? The main correlates for metabolic syndrome were high blood pressure, high BMI, and below secondary level of education. Again, correlates that can be addressed going forward to reduce the risk of cardiovascular disease for our women. And then we found that postpartum metabolic syndrome is associated with a 29% higher odds of or risk of developing high sensitivity, elevated levels of high sensitivity CRP. Again, it's important for us to know that inflammation is one of the underlying risk factors, either for developing hypertensive disorders in pregnancy or cardiovascular disease. And then lastly, from the cardiovascular function study, hypertensive disorders in pregnancy may be associated with increased left ventricular mass, which is a measure of left ventricular hypertrophy in the immediate postpartum period, and reduced global longitudinal strain as well at 2 to 3 years postpartum. This again is preliminary data, may have clinical implication, and is something that we need to address going forward, either through monitoring or interventions for the same. My last slide is just to say thank you to many teams. This study was funded by the National Institute of Health through Fogart International Center that I've been working with for several years now, especially the Office of Research on Women's Health, which awarded us the training grant specifically to look at risk of cardiovascular disease after pregnancy. IRTP, which is from the University of Washington, again funded by the NIH for training, which supported my training, including the doctorate level training, and some other 2 grants that we have from the NIH specifically for training and also looking at the cardiac dysfunction. I would also want to thank my mentors from the University of Washington, University of Nairobi. This work cannot be done without mentors. So I know they are not here unless Professor Kiari logged in. I didn't inform Kari because of the timing. So Kari from the University of Washington, James Kiari, that Kenyans we all know from the University of Nairobi and now at the WHO, and Dr. John Kinuthia that I'm grateful for giving me the forum and also holding my hand through the initial steps of being a fellow and continuing to conduct my MPH and PhD studies. Thank you, Dr. Kinuthia. This work was supported by an immediate former chair of the department, Professor Omondi Ogutu, who has been very helpful, instrumental in ensuring that all the things that we require are delivered on time. And the Department of OBGYN has housed me together with my research staff, so we are really grateful for them. KNH OBGYN department, Dr. Maranga, we started this study, and Dr. Witty have been both supportive. And then, as you probably know, I'm not a cardiologist, and I don't intend to be one. Dr. Getura Bernard from cardiology has been very helpful, giving us the sonographer to undergo the training and supporting us with the sonographer to help us do some of the evaluation. So if he's in, Dr. Getura, we are very grateful for your department. And then the staff that we worked with over time that have not left us, Margaret, Grace, Joyce, Joseph again, Mark, Teresia, Anne, and Rose from the lab as well. And then our study participants that made this study possible, as well as the KNH research department, that has really, really been instrumental in ensuring that our studies are conducted successfully, and also allowing us to present our findings. Thank you very much, and I will now take any questions.
Thank you very much, Dr. for that very, very elaborative research dissemination. I think we underestimate the amount of research we do in Kenya, and it's a very good initiative that we are learning from your research, and it's very, very informative. Some of the few questions that for the audience, you can address your questions on the Q&A, and Dr. will answer the ones he will be able to. So the first question is, was physical activity of study cohorts considered postpartum in those who frequent gyms in reducing blood pressure and metabolic syndrome? I think it's a very good question.
Okay, thank you. Thank you very much, Hilary, for that very important question. Yes, so we have the data. We have the data on physical activity. We have data on diet. We have data on exercise and everything else that goes with it, smoking, alcohol intake, and the rest. When we looked at the numbers that are involved in physical activity, they were very minuscule in the postpartum period. I think most of our women actually rest a lot in the postpartum period, which is okay because they need to recover from whatever is happening or whatever has happened. But the levels are pretty low. So when we looked for it and compared between the two groups, there was actually no difference. Yeah, so important question, yes. But the question we had, so we asked about the physical activity that they're involved in, exercise, how intense it is, using a standard WHO questionnaire for the same. Thank you.
Thank you. Thank you for even for seeing that there was not a lot of significant difference in exercise. Another question is, don't you think, this is from an anonymous person, don't you think the diet postpartum also has an effect on metabolic syndrome?
Yes, so thank you, the attendee. Yes, the diet has an impact on metabolic syndrome, definitely. And one of the treatments of metabolic syndrome is actually dietary advice, and you can use different types of diet. There are special diets that you can use, and you can work with a nutritionist to try and lower the risk of metabolic syndrome using diet. Yes, so we captured data on diet as well, including fruits and vegetables, carbohydrate intake, and the rest. And we're looking at basically healthy diets. Fruits, especially emphasizing on fruits and vegetables. And again, there were no differences between the two groups. So when we put it in the model, there was no differences at all. But going forward, when we're looking at interventions to try and reduce the risk of cardiovascular disease or even metabolic syndrome postpartum, we will recommend for our patients to have specific diets. Yes, so we looked at diet. It was not different between the two groups. And it's something that we need to address because of the high risk of metabolic syndrome going forward. Thank you.
Thank you very much. Nyainda Ogola is saying, thank you, Dr. Osoti, great presentation and great work. Then it's rather a clinical question from one of the attendees. I'm not sure if you would want to answer that, but another who had preeclampsia delivered at 7 months gestation to a baby at 1.8 kgs, 2 weeks postpartum, still the BPs are at 145/98, the heart rate at 102 beats per minute. She's on aldomate, 500 mg TDS, nifedipine, 20 mg BD. Urinalysis, they had a proteinuria of +1. What medication should we use to lower her BP?
Okay, thank you. That's more clinical question, but we'll try to answer. So one is patient need to be reviewed by at least an obstetrician or somebody with higher training in obstetrics to be able to be able to evaluate if there are other risk factors, or even the physicians also to review if there are risk factors, whether this patient has chronic hypertension or not. So that can be elicited from the history when we review the patient. But assuming the patient just developed preeclampsia in this pregnancy and had no other pre-existing conditions that need to be addressed, then you can continue with the same treatment, because the blood pressure will take time before it settles. So it can go up to, if preeclampsia, it can go up to 6 to 12 weeks postpartum. So you just need to continue the medications. Nifedipine might be difficult to take with a higher heart rate, and you don't want to go at a higher dose than that. So I would probably recommend amlodipine instead. So you can give like 10 milligrams once a day. The blood pressure are not too terrible, so you do not want to lower it beyond that. So you can give amlodipine 5 to 10 milligrams per day, and that may be a better control than nifedipine, especially because of the tachycardia. But just expect the blood pressures to linger on for a little bit. If they continue lingering beyond 12 weeks, then your patient has chronic hypertension. Again, this is just a clinical recommendation, but the patient may need to be seen by a specialist to address a health holistically.
Thank you. Thank you very much for that. This question I find quite interesting. How can you explain the low secondary education correlating to postpartum metabolic syndrome? Did you find an explanation?
Okay, thank you, Maureen. Good question. I think level of education determines several things. The kind of diet that you take, the kind of awareness that you have, concern about your weight, concern about exercise, and concerns about other things in general. So I tend to think that education, just like income, may affect your risk of metabolic syndrome based on the knowledge level that you have and what you can be able to afford to eat, whether you're able to afford a better diet, a more healthier diet than would be somebody who does not have a high, regular income and who has a lower level of education. So education will affect your lifestyle generally.
Thank you. I guess the key message is we do not underestimate the power of education and literacy levels. Did you consider family history of hypertension as a co-founder? This is also from an anonymous attendee.
Yes. The family history of hypertension. Yes, that was considered actually when we were screening patients, and mostly we found this to be associated with those patients who had pre-existing hypertension. So chronic hypertension is specifically, and most of those were actually excluded. So yes, we asked about family history of hypertension. We know that family history of hypertension is associated with a self-history of hypertension and also a self-history of preeclampsia as well. So we asked that particular question, yes. But we did not adjust for it because we didn't think that it was a confounder per se.
Okay, thank you. I'm not sure, but maybe you can just clarify. I think the inclusion criteria, you recruited most people when they were past 6 months. So this question is, there's a tendency to overeat during the first 6 months. So are the clients on special diets to reduce metabolic syndrome?
Okay.
Maybe there's a better way you can answer that.
Okay, thank you. Thank you for the question, Faith. So we were not intervening. So we are not intervening at all. We're just trying to see, are these patients at risk, or do these patients have metabolic syndrome? So it was an observational study. So an observational study, you just follow people the way they are. You do not intervene at all. So we hope going forward that we can now start, doing dietary advice and trying to see whether that would influence the risk of metabolic syndrome or even the resolution of metabolic syndrome going forward. So because it was a non-intervention study, it was just an observational study, we did not actually or recommend any special diet. In situations where patients ask what they should eat, then we just told them what is healthy that they should eat. But it was not an intervention, so we did not give it to everybody because it was just an observational study. Now, this whole idea of telling pregnant women to eat for 2 or more, or to overeat during the postpartum period is not actually recommended, because that's what we used to, people used to tell them in the past. They just need to have a balanced diet and eat healthily, but don't force them to eat lots of ugali and lots of, all other foods which may not be healthy for them, okay? So long as they are taking adequately and nutritious food, it's okay. Again, you raise an important point. Overeating within the first 6 months. We should not encourage that. We should discourage it. They should just eat enough and not force them to overeat. Thank you.
Thank you very much. So take home message, do not eat for 2 or 3 or 4, depending on how many kids you're having. Dr. Simon Kibias is asking, you mentioned that gestational diabetes prevalence is influenced by the level of screening done. Would you be recommending routine RBS to all pregnant women, or fasting blood sugar to all pregnant women?
Thank you, Dr. Kibias. That's a very good question. And I think we need to move to the next level with screening for gestational diabetes, because we do a very poor job at screening. And when we wait for these patients to have overt diabetes, it will be too late. For example, there are cases where we do random blood sugar. At least we are trying now to do random blood sugar. Most facilities are actually doing random blood sugar. But if you look at the pathophysiology of gestational diabetes, if a patient is going to develop gestational diabetes, usually be in the second, third trimester, 24 to 28 weeks is when we typically screen them. But when you look at the RBS that we do, typically we do it in the first visit. So we have had patients who have a normal random blood sugar in the first visit or second visit in the first trimester, and then they present with overt, diabetes or gestational diabetes later beyond 24 weeks. So in as much as the RBS may help us identify those who are overtly diabetes in the first trimester, it may not be that helpful. And also fasting blood sugar, there are so many patients that we miss. So I would recommend, and that's what we are doing for most of our patients, either glucose challenge test with 50 grams of glucose, or an OGTT if you are able to. That would be the best recommendation. So where we have done studies, and these have been published, you can look at Yogeka by Dr. Suha. She looked at just screening women and offering them glucose challenge test. We found more than 20% of our women actually have gestational diabetes if you do universal screening. And in normal circumstances, we don't do universal screening, you end up with less than 2% in some settings. So poor screening is why we have a lower prevalence. When you do proper screening, then you will get a higher prevalence. If you wait for them to manifest with symptoms, then you'll be getting the range of 1% or even less. So that would not be recommended. And unfortunately, for those of us who work in referral institutions, despite patients presenting with obvious clinical features suggestive of gestational diabetes, sometimes they end up without even being screened at all when they deliver and go home. So we are not doing a very good job at it. As you are in the ministry, probably you can liaise with your colleagues in the public health as well to try and see whether we can even start with just a glucose challenge test, even if it's not an OGTT, to help us get some of these women who are not diagnosed as having gestational diabetes. Thank you.
Thank you very much. A lot of comments on it's a well-articulated presentation and great information from Clarice, Julia, and Daniel Okich. Yes. Janet Kibugi is asking, do you think it's possible to come up with a preventative program and have it adopted by MOH?
Yes, thank you, Janet. I think that is the next level that we want to consider to try and communicate our evidence to, this is first step of dissemination to colleagues and also to stakeholders like you. And then we will relay this evidence to our ministry. And then the ministry will try to figure out what is the best way in which we can, not burden our healthcare system, but also ensure that these women who are at risk are properly followed up. So that will be the next level. And, in the next stakeholders meeting that we have, I will request to at least present our work. Dr. Kibias here from Public Health as well can be able to help us link up with the public health team so that at least we can be able to share this data with them. Yeah, but at an individual level, if you're taking care of these women, please just ensure that you follow them up beyond the puerperia.
Thank you. Thank you. Faith is asking, do you consider that some women were already obese or overweight before pregnancy, and that by itself can be a risk, can affect them having metabolic syndrome postpartum?
Thank you, Faith. So that's a very good question as well. So, well, as you probably know, it's very difficult in our setup to get our women before pregnancy. Even in private practice, it's a bit difficult to get most women before pregnancy unless they had some issues before, or they're just, very well informed people who know about preconception care. So there could be a possibility that some of these patients may have had pre-existing metabolic syndrome, which had not manifested. And therefore, that is why they have postpartum metabolic syndrome as well. But we did our level best to exclude those who had pre-existing metabolic syndrome. So for those who had, high blood pressure, most of the patients who are obese will either have high blood pressure, or they will have, diabetes or hyperglycemia of some sort, or they will be on some sort of treatment for the same. So those who had risk factors, things like polycystic ovary syndrome, who are on treatment, we actually excluded. That's why we also excluded those who are having HIV infection because of their risk of developing metabolic syndrome. So there could be a small number that could have had pre-existing metabolic syndrome. And that's why we may have a slightly higher metabolic syndrome, in the normotensive group as well. But we tried our level best to eliminate that by looking at their treatments before and some of the risk factors for metabolic syndrome. Thank you.
Thank you. Again, a lot of thank you very much from Anonymous Presentee and George Ombak. The Anonymous made a very interesting comment that he noted, or she noted, that the average height of the study was 141 centimeters. Most women, I think their height was at 141 centimeters. Maybe Dr. your team had a bias in recruiting that height.
No, that was the average. So you'll find people who are taller and people who are shorter, but now when you look at the mean, then that's what basically you'll get. And the fact that there was no difference between the two groups, then it also shows that our patients tend to be more or less of the same height. And I think that's generally what's happening, except now for the weight, that would give them a high BMI. Yeah.
Thank you. Maurice Walker is saying, great presentation. In this era of digital technology, do you think we have quality health apps to help in prevention of such conditions? Are there any recommended ones to suggest?
Okay, great question, Maurice. So in this era of technology, you have everything about keto diet, whatever else you want, you can do. You have apps for pregnancy and the postpartum period as well. There's most of these apps are commercial, so they are not really tested ethically, so that at least you can be able to say that this app works to reduce the risk of metabolic syndrome or risk of cardiovascular disease. So again, as more evidence comes, as you can see from the presentation, that most of this evidence is building up, and probably in the last 5 years or so, hopefully we'll have apps that people can use to say, this is my weight, this is my BMI, this is the diet that I need to take. And going forward, if you want to look at interventions, then I think this is one of the ways in which we can put interventions to help remind our participants of what to do to reduce their risk of metabolic syndrome. Yeah, so great idea, but we don't have any apps that I can recommend at the moment over the same.
Thank you. An anonymous attendee is asking, going forward, will you collect data on possible modified behavior by participants?
Yes, so we will collect data going forward. Unfortunately or fortunately, the grant that we had was just looking at the risk of metabolic syndrome. Life is busy, but we'll try to write and make requests for additional grants to look at interventions. So when we can look at interventions going forward, then we can address some of these outcomes. So once we have, decided, and we are thinking we can even do it in pregnancy. Once we have diagnosed somebody with metabolic syndrome in pregnancy, we can try and see whether we can, give them proper diet, use some medical treatments if available to try and lower their risk of developing these adverse pregnancy outcomes, and also continue with that in the postpartum period to see if we can reduce their risk of developing cardiovascular disease going forward. Yes, so going forward, that's what we are thinking of. Once you've estimated the burden, which is pretty high, then the next level is how do you reduce this burden? Okay, and maybe I didn't present some of the data here, but you realize that some of our patients are still quite hypertensive, even 1 to 3 years postpartum, and some of them are admitted even with hypertensive crisis after, yeah.
Yeah, thank you. Just for my own understanding, since I can see most of the questions have been addressed, what is the relation of, if there is one, with hypertension in pregnancy with postpartum cardiomyopathy? Were you seeing a lot of that? And are they the ones that were causing mortalities?
Yeah, great question. So preeclampsia per se may not be associated with postpartum cardiomyopathy per se in terms of, increased risk. Of course, we know that preeclampsia from the studies that we've just done may be associated with some left ventricular hypertrophy of some sort, but we tend to see postpartum cardiomyopathy in patients with probably viral infections or other risk factors as well. The theory now is that maybe higher levels of prolactin may be responsible for postpartum cardiomyopathy in those patients who get it, and use of treatment to lower the prolactin levels have been mentioned as well. And as you probably remember that, for peripartum cardiomyopathy, some of these patients are relatively okay, no blood pressures or anything. They go home and then maybe somewhere within 6 weeks or after, even up to 4 months or 6 months, within the first year postpartum, they end up developing this cardiomyopathy. Yeah. So we don't know the etiology, but we know there are risk factors, including things like viral infections, which have been attributed to it. And now the thinking is the high prolactin levels. Yeah. So no direct correlation per se. It may be just coincidental. Yeah. But that's what I would say about peripartum cardiomyopathy.
Thank you.
Yes, Dr. Ogola is saying it's actually a risk factor for postpartum cardiomyopathy. Yes, it is. It is a risk factor. Yeah, but yeah.
Okay. Then from the sonographer, it was a very interesting name. I don't know. I didn't write it down, unfortunately. Do we have any other sonographer trained in Kenya on that particular thing? Is it something that you can routinely do, or it's just specifically for the study?
Yes, so that was part of the plan that we will get the sonographer to train their colleagues on this. And again, initially it was just for the study itself, but we hope that once we are through with the study and the recruitment, then we'll have a structured program in which Joseph, the sonographer, can help to train the colleagues. And also for those researchers who are at KNH who are thinking of doing studies using Speckle tracking, echocardiography, please, you are welcome to reach out to us, reach out to our cardiologist, Dr. Gitura, Professor Ogola, and the rest, so that at least we can be able to allow them to use the machine. So we hope that we can be a center for training going forward, so that at least we can train some of our echo techs and cardiology sonographers who are not familiar with it on the method. It's quite interesting, not difficult to learn, as Joseph told me, and as I also went to the US for about 2 weeks to sort of learn, what to talk about, like I'm talking about today. So it's very interesting. It's something that can be easily done once you have the machine, and we hope that Joseph can train more people going forward. All right, we are done, Amina.
Oh, Sorry, yes, we are done, but just one quick question regarding the technology aspect, or rather it's a comment really. If you ever think about having a patient portal for especially the population of maternity is quite an interesting one. I'm sure we'll have many people who would want to recruit them such that they have information about their health information or whatever. And you can also have the studies uplifted there such that if they want to enter the clinical trial or whichever study which is available in terms of maternity in Kenya, I think it would be a very helpful thing. Maybe Dr. Aswati would also get funding for that the next time we get a grant to look in maternity as well. I don't know if any of the other people who are guests would like to make any comments. Dr. Zainab Dida? Anne Pulei?
Yeah. No comments. Thank you.
No comments. Just, great presentation from Dr. Sochi. Always nice hearing.
Thank you so much.
Thank you very much,
the occasion as well. Yeah, I can see my chairman, Professor Mondio Gutu, may say something.
Thank you, Alfred. Very, very good presentation of the work you have done over the years. I know there's been lots of challenges when you started, but I think this work is very informative. It informs us of a lot of things which we have been missing out, is especially addressing the non-communicable diseases, some of which were thought that are of no significance in our setup. And especially when you look at the abnormal glucose tolerance, you remember there was a very early study which was done in I think was it in 2006, much earlier, by Dr. Baraza, who from the study she did, which had got maybe a few limitations, gave us the idea that at least 32% of abnormal glucose tolerance, which was being seen in our clinic, with the refined studies which was done by Sura and also what Dr. Soti has done, has showed us that this is a problem for which we need to do much more, take more precautions in it, so that we are able to have our women getting better care within the setup, and also informs the rest of the clinical providers in the country that the multidisciplinary approach in management of most of these conditions is what informs the good and eventual outcome of the women and the babies they deliver. So I need again to congratulate Dr. Soti for the excellent work done and the excellent work he's still continuing to do in this area. And with progress towards having our fellowship program, these are the kind of things which we'll now be expecting our colleagues to be excelling in. Thank you, Dr. Soti, and all the people who ensured that this study had quite an outstanding achievement, including our colleague from the University of Washington. Thank you.
Thank you, Professor.
Thank you.
Okay, back to you.
Thank you very much. Yeah, thank you very much, Professor, for that very concise remarks. Thank you, Dr. Soti. I don't know if you have any parting shot.
Thank you. I'm just grateful for the wide spectrum of attendees and their contributions. You've been very engaging, which is I'm grateful for. And also special thanks to Dr. Kinuthia and the KNH team for giving us this opportunity to present our work. Thank you very much.
Thank you. Just a reminder, on Friday, we'll be having our session on experiences managing COVID-19. The oxygen series, it will be part 5. And if you did not catch up with the other ones, you can always get it on the KNH Research YouTube channel. Thank you very much for your attendance. See you next time.